Okay, I have to talk about the meniscus repair and the roll-up posterior approach for that, this technique. This is my disclosure, and this is my article about the meniscus repair that I published recently. And I talk about forgotten posterior knee arthroscopy. Knee is not only the anterior compartment. You have two compartments, anterior and posterior. You have to consider posterior compartment too. And I believe that the fracture non-union management principles works for the meniscus repair also. You have to debride and removal of fibrous tissue. You have to have anatomical reduction. You have to good secure fixation to have stability, and you have to have healing enhancement, use healing enhancement technique. This is the female, 38 years old, bucket handle medial meniscus tear and also radial tear in the posterior tear. Oh, what can I do for this kind of the tear? What's the solution? Meniscectomy and think about the future HTO and meniscal transplantation or UKA. As you know, the peak contact pressure increased significantly after the total meniscectomy, and the second option is the meniscal repair. And you know that meniscus help the ACL and the ACL help the meniscus too, and both of them preserve the cartilage. So I'm going for the meniscus repair. At first, I do in situ debridement. When the meniscus is in the notch, I debride the meniscal border to remove the fibrous tissue, and then replace the meniscus to the notch. Like this. So, now this is the reduced picture of the patient. If you look at this picture, you see the chondral lesion. I did the meniscectomy, what happened for this patient? So, always I use in the lithotomy position, the knee is in 90 degree, I use the posterior knee approach, and I transverse the septum. And in the right picture, you see the medial and lateral femoral condyle, but I remove the septum, and this is the picture that I showed how I can pass the septum from the posterior. I can pass from the lateral to medial and medial to the lateral too. So, this is the posterolateral transseptal view of this patient. Imagine what happened in the posterior part and how you can debride the meniscal border from the anterior and repair it. This is necessary for healing. As a fracture management, if you reduce the fracture non-union and don't debridement from the fracture up to healthy tissue, the repair not be successful. So, why I use the posterior approach now? From the anterior, you need to MCL release, you need to valgus stress, your risk is cartilage injury from the anterior is high. You can put horizontal matrix suture from the anterior, but from the posterior, you can put vertical matrix suture with higher biomechanical strength. And you can entrap the circumferential fiber too. And you can do ablation and healing enhancement technique from the posterior, very simple. So, I debride the meniscal border like this. And you see the picture from the left side, from the posterolateral, and here from the posteromedial. And this is the septum, a PCL. So, what I do now, I abrade the posteromedial part of the tibial plateau up to cancellous bone because I believe that inside the clot make here. And there is no need to put inside the clot after the repair. As you know, the majority of meniscal incomplete healing is in the posterior part of the medial meniscus. Literature show us. So I abrade, and finally I have this picture. So I'm going to repair with suture passer, like this. You see the peripheral part is inferior location. How you can bring the peripheral part to the same level and repair it? It's not possible from the anterior. You have to bring the peripheral part to the same level. And I use here the shutter relay system to bring the peripheral part to the same level and has the maximal contact to have maximal healing. So this is the final repair. You see from the posteromedial and posterolateral. And this is the anterior view again, and check for stability. And sometimes I put one stitch in the anterior because I believe that the posterior part is too important, like a Bankart lesion. If you repair the posterior part, there is no need to put more suture in the anterior part. I only put one suture in the anterior third. I just only abrade the meniscal border in the mid-third because I believe that if you put the stitch in the middle part, risk of arthrophyrosis due to MCL irritation will be high. This is the check for stability from the anterior. So this is another technique that for the unreducible and unstable bucket handle medial meniscus. That means Lyme type 3, that the meniscus has 180-100 rotation. When if you reduce the meniscus into the notch, the meniscus come back again to the notch again. And so I use the meniscal angiocat to provisionally fix the meniscus from the anterior, like provisional fracture fixation. So I reduce the meniscus into the notch, and then I use the needle to provisional fixation of the meniscus. You see the needle from the anterior and then from the posterior. Finished. So this is the pre and post operative again, and pre and post operative. And this is the escort that you see the IKDC and lesion score significantly increase. As a take-home message, posterior arthroscopy leads to excellent clinical result, is safe and practical, and has many advantages, and must be part of the education. Thank you.